Hi, this is Ryan Miller. This is a presentation and an overview of bipolar disorder. This presentation is based on a case study and will cover the different treatments and options used to address bipolar disorder and potential complications that one can run into while trying to treat this disorder. This slide is a video introduction for the PowerPoint. It's about 8 minutes long, and I will be discussing the definition, the history and origin of bipolar, and some of the key diagnostic criteria as listed in the DSM-5. Please click on the link to watch the video. Before we go into the case study, I want to make sure that we understand the criteria for the symptoms that therapists look for in bipolar. The first of which is mania. The criteria for mania is very specific, and in order to be considered a manic episode, they have to have at least 3 of the following symptoms as listed here. These symptoms could be inflated self-esteem or grandiosity, decreased need for sleep, becoming more talkative than usual, or pressure to keep talking. One could experience flight of ideas or subjective experiences that thoughts are racing. Also, attention is easily drawn to unimportant or irrelevant items. There is an increase in goal-directed activity or psychomotor agitation, and also excessive involvement in pleasurable activities that have a high potential for painful consequences. Another symptom would be the depressive episodes. In order to meet the criteria for a depressive episode, one must meet 5 or more of the following symptoms listed here. Some of the symptoms are depressed mood for most of the day, a diminished interest in activities that were once pleasurable. There can be a noticeable increase or decrease in weight. One might become more tired or not as tired, sleeping too much or not enough. During a state of depression, people can move slower and show physical agitation. The daily fatigue becomes more noticeable. There are feelings of worthlessness and guilt. Also, uncharacteristic indecisiveness or diminished ability to think clearly and stay focused on tasks. Also, recurrent thoughts of death or suicide. And as I mentioned in my introduction, these symptoms, to qualify, cannot be brought on by an external factor, such as loss of a loved one or drug use that is causing these feelings. These feelings have to be brought on and have no connection to any certain event or circumstance that might have brought them on. Here we see the criteria for hypomania. Hypomania is a lesser version of an actual manic episode. These are important in diagnosing bipolar 2. Some of the symptoms have to be met for hypomania are listed below. They include an inflated self-esteem or grandiosity, decreased need for sleep, becoming more talkative than usual or pressure to keep talking, the flight of ideas or subjective experiences that thoughts are racing. Attention can be easily drawn to unimportant or irrelevant items. There is an increase in goal-directed activity or psychomotor agitation, and an excessive involvement in pleasurable activities that have a high potential for painful consequences. A lot of these symptoms you see in a diagnosis of a manic episode. but there is a difference between the manic and the hypomanic episodes. Hypomania is shorter in duration. To have a hypomanic episode, 4 days is enough for it to qualify as an actual hypomanic episode. And these episodes don't cause impairment in functioning daily to the point of hospitalization or completely impairing your ability to work or socialize. Now that we've discussed the different states, manic state, depressive state, hypomanic state, the criteria for bipolar 1 and bipolar 2 will make more sense. They have to also meet criteria based on these episodes. So when we put it all together, the differences of bipolar 1 and bipolar 2 symptoms are listed and compared. For bipolar 1, the criteria has to have been met for at least one manic episode. Also, the symptoms have to cause social and occupational distress or impairment. Symptoms cannot be accounted for by other similar mental disorders. For bipolar 2, the criteria has to have been met for at least one major depressive episode. Also, criteria has to have been met for at least one hypomanic episode. There can be no history of a manic episode. With that being said, once the hypomanic episode becomes a manic episode, the diagnosis will change from bipolar 2 to bipolar 1. For bipolar 2, another symptom indication would be that the symptoms cause social occupational distress or impairment, but again, not to the extreme or extent of bipolar 1, where one might be hospitalized or lose their job, family, and other events that are crucial in our life. And lastly, the symptoms cannot be accounted for by other similar mental disorders. Now we get to meet Erin M., our case study. She is 39 years old. She stands at 5'7" and weighs 135 pounds. She is in good physical health and shows no signs of any physical impairments. Knowing a patient's family and medical history is important. For Erin, we discussed her physical appearance. She is 5'7" and weighs 135 pounds. She is a white, 39-year-old female. She is a single mother of 3 children. She was raised by a single mother who was not very present in her upbringing. Her father, although not living with her, was in her life. He had a history of alcoholism, even though he had been sober for 42 years, and Erin never really knew him as an active alcoholic. Erin's sister is a recovering addict. Erin has no major medical issues. At the age of 9, she was diagnosed with depression. At the age of 16, she had an outpatient stay in a mental health facility after she had attempted suicide. When Erin was 9, she began to see a therapist when her mom noticed unusual signs of depression. She was quickly diagnosed with depression and about a year later began taking Lexapro. She continued this course of treatment for 5 years with some positive results, but not enough to relieve the concerns her mom had about her behavior. Not only did her depression come back after almost 2 years, but other behaviors began to emerge that were disturbing and alarming to her mother. Erin took herself off the medicine when she was 14 and stayed unmedicated until her 26th birthday. During that gap, She was kicked out of 2 high schools. She eventually earned her GED. At 16, she attempted suicide by overdosing on over-the-counter medicine and subsequently was admitted as an outpatient at a mental health facility. Her substance abuse also began around this time. She had her stomach pumped on 2 occasions after consuming more alcohol than her body could handle. She began popping pills, painkillers like hydrocodone. They were another drug of choice. It helped her to subdue the anger and depression she constantly felt. She gave birth to her first son at the age of 19 and married and divorced the father within the first year. During her second marriage, it was then that Erin began to tire of her unstable life and emotions. She began to see a therapist who recommended her to a psychiatrist. It was at this point she was diagnosed with bipolar 2, and she began treatment to help her cope and live with the depression and mania. Here are a list of several medications used in the treatment of bipolar. Mood stabilizers are often used to help level the moods. Some of these medicines are lithium, carbamazepine, lamotrigine, and valproic acid. And in conjunction with the stabilizers, antipsychotics are often used as well. There is a list of typical antipsychotics on the slide: Risperdal, Clozaril, Zyprexa, Seroquel, Guiadon, Abilify, Rynapt, Latuda, and Vega. There are other types of antipsychotics, and also other types of medicines are used when treating bipolar, as there are other symptoms usually present other than the mania and depression, often symptoms of ADHD, anxiety, and other mental issues can be treated in conjunction with the mood stabilizers and antipsychotics. Adjunctive therapy. This is a combination of drug and therapy to reach optimal results. Medicine alone or therapy alone is usually not effective in managing the symptoms of bipolar. Adjunctive therapy, the combination of drug and traditional therapy, is a common treatment plan for those with bipolar disorder. There are several therapy treatments used to treat bipolar. You can do the traditional individual, group, or family therapy, where you talk with a counselor on a regular basis to discuss and work through ongoing issues related to the disorder. There's also cognitive behavioral therapy. This is a therapy used to help discover and change some of the unusual responses and thoughts that contribute to the bipolar disorder. And also interpersonal psychotherapy. This is a therapy done within a short period of time. It focuses on interpersonal problems and working through them to resolve the issues. As I said, this treatment is done in a short period of time and usually completed within 12 to 6 weeks. On this slide, we see Erin's adjunctive therapy plan specific to Erin. She is on several medicines. She is taking 70 milligrams of Vyvanse, 30 milligrams of Adderall. These two are addressing her issues with ADHD and focus. She is on lamotrigine at 200 milligrams. This is a mood stabilizer. She is taking 120 milligrams of Latuda. This is an antipsychotic. And she takes 1 milligram to 2 milligrams of lorazepam as needed for moments of anxiety or extreme irritability. Erin has also decided to go to therapy to help the medicines work and help her learn new skills. She goes to a therapist every 2 weeks to talk about her moods, and then to a psychiatrist monthly to monitor her medicines. She just recently started cognitive behavioral therapy, and she is hoping to learn some of these skills that will help her become more aware and in control of her extreme mood changes. When treating someone with bipolar, you can run into several issues. These are not always the most compliant patients. Erin's therapist have run into a few roadblocks. On the slide, I listed a few of those roadblocks that they specifically have run into. Managing her medication properly. Erin tends to get off of her medicine on her own, whether it's forgetfulness or feelings of it's not the right medicine. Learning some new social skills has been an issue with Erin as well. Not always open to learning these skills or unwilling to see that there is a need for a change in behavior. Educating her parents and her significant other has also been a challenge, as not everybody wants to acknowledge the issue or acknowledge that they need to take part in the treatment plan. And also repairing the damage done in Erin's social and occupational surroundings that were brought on by her bipolar have been an issue. A lot of these things, such as her losing her job and having 2 failed marriages, have been a result of her bipolar. And to work through the issues and repairing that damage has proven to be quite a struggle. If you or anyone you know suffers from bipolar disorder, please encourage them to get help. It is a disorder that people will have for the duration of their life, but they can manage extremely well when they take medicine and therapy and use them correctly and consistently. Thank you very much.